so I think we can start, right, dear colleagues, dear Kostas, dear Nicola. We are very happy to be with you today, and we're now going to give, or I'm going to give a short presentation on our ARISTON project, and afterwards there will be plenty of time for discussion. So I will just try to share my screen. I hope you can see the presentation. Please just give me a sign. Thank you, Nicola. So the project is called ARISTON. ARISTON is, like in Greece, excellent, and we are going to talk about the atherectomy assisted endovascular versus open repair, especially for lesions in the groin, atherosclerotic lesions of the common femoral artery. So, of course, as we all know, surgery is the gold standard for this vascular region. Why is that the case? Because with open repair, you can get out the entire atherosclerotic burden area with a high surgical precision. And this technique has shown long-term durability data in previous studies. So you can see on the left side, we are talking about patency rates of over 95% at 7 years of follow-up, which has been reproduced also in other studies. On the other hand, there is also another side of surgery because, of course, you may deal with complications like lymph leaks or wound infection, especially in patients with adipositas, and of course also with hematoma. We know from a registry that has been published a couple of years ago that the complication rate after surgical endotherectomy is not that low as expected, and there is a high morbidity and mortality rates, especially in frail patients that are older than 80 years old. On the other hand, when looking at, when searching for more minimal invasive techniques in order to address such atherosclerotic lesions, atherectomy is a relatively new technique in order to tackle such lesions. We know that with atherectomy, you can remove plaque minimally invasively, without the need for open surgery. On the other hand, by atherectomy, lots of calcified plaque components can be removed effectively. This decreases the barotrauma with the subsequent balloon angioplasty, and also after removal of that tissue, you have probably a better deliverability of the drug into the vessel wall, especially when using DCB therapy. These are the theoretical advantages of atherectomy, and lots of these advantages have also been currently confirmed in meta-analysis studies. The vessel compliance can be improved. The rate of dissections is lower after performing atherectomy. Barotrauma is lower, and the stent rate or the rate of bailout stenting is also lower, especially, of course, in the common femoral artery. This is a very important thing we have to think about, because the common femoral artery is also an excellent potential bypass landing zone for future interventions. These are some data from a non-randomized study. This is the largest study retrospective that has used directional atherectomy for the treatment of common femoral arteries, and you see a very acceptable TLR rate during follow-up. And this is our smaller experience with the Phoenix atherectomy device, reported on about 50 patients, where we also see an acceptable rate of TLR at 2 years. This is an example. So this shows a bifurcation lesion in the common femoral artery, as you can see, in the groin. And after performing atherectomy with a 7 French Phoenix atherectomy device, which actually combines directional and rotational patterns, you can see a pretty nice result. After debulking and after kissing balloon implantation, on the right side, you can see a very acceptable acute result after atherectomy and DCB in this case. The objective of the ARISTON trial is to investigate the effectiveness and the safety of endovascular versus open revascularization techniques for the treatment of patients with CFA lesions within a real-world registry. We will include patients with claudication, rest pain, or critical limb ischemia, Rutherford category 5, not Rutherford category 6, which are referred to centers for CFA stenosis or occlusion. The outcomes will be the improvement, of course, the clinical success after open surgery or intervention in terms of Rutherford category and in terms of clinically driven TLR. It will be a multi-center retrospective and observational study period between 2015 and 2021, and all comers will be included with symptomatic peripheral artery disease. We decided after consensus and discussions that we should use the rather new classification by Rabellino et al. Probably most of you know the AZEMA classification for CFA occlusive disease, which classifies lesions by localization, bifurcation versus non-bifurcation lesions. The advantage of this pattern by Rabellino et al. Is also that it combines the anatomical characteristics with the grade of calcification, which is also very important in the selection of patients and how to treat them by open surgery or by endovascular means. So the inclusion criteria are symptomatic PAD, Rutherford categories 2, 3, 4, or 5, CFA de novo lesions or lesions after surgery with recurrent stenosis. Of course, the lesions have to be more than 50% by angiography or by CT evaluation. As already mentioned, the Rabellino classification will be used. Patients will be included that have at least a run-off artery in the PTK vessels of 1. The endovascular procedure has to have been successful, and the guide wire needs to have been crossed intraluminally. We will also include actually patients treated with isolated POBA or primary stenting, but of course we're more interested in the patients that have been treated with the best endovascular treatment, in our opinion nowadays, which is atherectomy, or alternatively perhaps a subgroup analysis with lithotripsy. On the other hand, the surgical revascularization techniques will also be included as patch atherectomy or a direct suture of the common femoral artery with or without involvement of the distal portion of the external iliac artery and of the femoral bifurcation. And of course, a hybrid approach with stenting of the common femoral artery to optimize inflow is also allowed. Similarly, an inflow treatment with the endovascular arm is allowed for an ipsilateral occlusion or stenosis of the iliac arteries, and also ipsilateral femoral popliteal artery disease is allowed. Task A, C, or B or C, we would like to exclude very complex femoral task D lesions from our analysis. Again, the exclusion criteria is the evidence of thrombotic lesions, ipsilateral femoral popliteal lesions task D, and patients that present with gangrene with Rutherford category 6. And we are also interested in octogenarians. So these are some patients with subgroups, patients over 70 years, but with significant cardiovascular comorbidities, such as unstable coronary artery disease or heart failure. And of course, we are also interested in lesion-specific parameters, such as, for example, patients with CFI lesions very strongly calcified, or lesions that also include the femoral bifurcation. The outcomes, of course, this is a retrospective study, so the outcomes we would like to focus on is the clinically driven target lesion revascularization, if available, but this is not mandatory, stenosis confirmed by ABI or duplex sonography. Important, of course, the mortality rates during 30-day of follow-up. Endovascular complications are very important, such as pseudoaneurysm or bleeding requiring surgery or peripheral embolization in conjunction with the use of filter devices. And for the surgery, complications such as wound complications, lymphuria, reoperations, wounds requiring VAC treatment, and persistent nerve irritation, influencing life quality. The length of hospital stay needs to be reported, and also clinical success is an outcome which will be referred based on the improvement of the Rutherford category. So I'm happy to have reported the basic let's say, characteristics of our study, and I think Kostas will probably want to add on that, and of course afterwards